Hi, this is Dr. Kathy Vierhusen, and we're going to be going over week 11 in 340, Community Wellness. And this week we're going to be talking about care of vulnerable populations. We're actually going to spend 2 weeks on this module, so we can talk about vulnerable populations in various ways. I apologize, I've got my allergies going right now, so I am not sick, I'm feeling very well. But let's hop into it so we can get this going for you. I'm going to share my screen as we always do. Excellent. Okay, so I trust that you can see my PowerPoint screen now, caring for vulnerable populations. Before we start, I do want to give a little bit of explanation about triggers. I don't know if you're aware of it, but different things can trigger our patients or ourselves for emotional responses when we don't expect it. One of them, and a perfect example of it, is actually when we're talking about sexual assault and domestic violence, which is what we're going to be talking about today. Sexual assault and domestic violence can happen in any family, and in a class of our size with 33 students, I would imagine probably 5, 6, 7 people may have been affected in their lifetime by themselves or someone they loved by an assault or domestic violence within their homes. A trigger is when something we talk about or something you see or something somebody experiences, maybe a noise or a sound, brings them back to the moment of the attack or reminds them really vividly of what's going on. And they can have a visceral reaction to that. They can have a reaction that is not something that they can control, but can cause them emotional pain. And how you might see this with someone is they could be triggered and they may shut down. They may not respond whatsoever. They may be triggered, they may cry. They may be triggered and they may want to leave. And I just want to let you know that if you're triggered by anything that are in these slides or anything that we go over this week, you have my permission to be able to skip over that section, be able to learn and glean as much as you can. But my idea here is that you are not being forced to talk about sexual assault or domestic violence if that is something that makes you extremely uncomfortable. It's important for all nurses to understand about these occurrences because violence against victims, survivors, is very prevalent in our society, actually in the world. Some areas are much worse than ours is. So I just want to start out by saying that you would always want to preface anytime you would be giving a presentation on sexual violence or domestic abuse or anything else that could be emotionally triggering. Maybe it's, talking about an experience in the war, of a medic in the war. You would need to make sure that that you let people know that it's okay if they need to get up and leave or if they need to seek other services. Plus, if anything would happen to you while you're here at the university, you can always reach out to health services in order to seek those services that would assist you. If you don't feel comfortable reaching out to them, and I will let you know that they are very confidential, but if you don't feel comfortable with that, you would want to research resources within the area, such as RAIN, which is the Domestic Violence Helpline, the RAPE helpline. You would want to look at those and be able to seek the resources you need. Okay, if you have any questions on that, or if you need ever to talk to somebody about it, reach out to me, okay? All right, so when we talk about sexual assault, one of the things that can be very misunderstood is that sexual assault is really about power and control. Excuse me, it's not about sex at all. Not sexual relationships that we understand to be those that have been given to us as having intimate relations and given to us as a gift by God. These are relationships that have may not even be a relationship, or they may be relationships that are based on someone exerting power and control over another individual. And usually what happens when somebody does that is that they can be very upset when somebody is going to end that relationship. The other situation might be that you've heard of pedophiles. Those are individuals who are interested in having sex with children or viewing pornography that has sex with children. As you know, as you can well imagine, it just is common sense. Children cannot give consent for sex. I'll tell you, even in Wisconsin, somebody under the age of 18 shouldn't be able to give consent for sex. But we know that as somebody matures, that becomes a little bit more of a gray area. But with children, when a pedophile is attracted to a child, many times they will be unattracted when that child starts to reach maturity. We're going to talk a little bit about these sensitive topics, and just because I think it's important for you to know. When we look at this slide, this collage of individuals, all of these people could be victims of sexual assault or domestic violence. We have on here children. We have on here the elderly. The youngest, as you know, I'm a forensic nurse. I see patients that have been sexually assaulted or have had violent acts against them. The youngest I've seen has been an infant. The oldest I've seen has been almost 100 years old. So age really doesn't have anything to do with it. You see on this collage people of all ethnic groups, not all, but many ethnic groups, and then different races. And that really has nothing to do with it either. You see on here individuals who are transgender. They may be gender fluid. We also have individuals on here that may be intellectually delayed. All of these situations, all of these individuals have situations in their lives that make them vulnerable. And predators, who are the assailants in these situations, seek out someone who's vulnerable. It may be somebody who's too young to be able to seek help. It may be somebody who's too old or demented who could seek help. It may be someone who is intellectually delayed where nobody's going to believe their story. That's what the predator thinks. Or it may be someone, such as a child, who the predator has said, you know what, this is a secret between you and me, and that predator has actually groomed them to respond to them a certain way. All right. So societal violence is very prevalent right now, and we have different kinds. So we have self-harm, which is when someone feels that the pain they're going to undergo because of harming themselves far outweighs the emotional pain. So the physical pain is better than the emotional pain for that individual. And so you may see cutting. Sometimes you'll see scars on somebody's wrists or on their thighs or on their stomach where they've cut themselves. And that is a way to release their emotions and help them to concentrate on something besides the emotional torture that they're going through. And the ultimate of that is, of course, suicide. We also have interpersonal violence. That is violence that happens between one or more people. So we have assault and murder. We have sexual assault, domestic violence, child abuse, elder abuse, and as I said, those who are cognitively or physically impaired. I want to say something just a moment about forensic nursing. We're going to be going through this, and forensic nursing really covers not only sexual assault nurse examiners who also have expanded their practice, such as mine, to see victims of assault, stranger assaults that may not have involved sex at all. They could have been a physical assault, emotional abuse, domestic violence. I'll give you an example. I took care of a patient one time when her husband had been upset about something that she said after they had gone to a movie. She had thought they had had a wonderful time at the movie. They got into the car. He got upset about something, took the back of her head and forcibly struck it then against the center console, breaking her nose and her jaw. So the forensic nurses would then go in and assess that situation, make a safety plan for that individual after we take care of their physical needs, and then we would document and collect evidence for court hearings and for restraining order stuff like that. So the nursing care of victims of violent crimes, these are the things that you should keep in mind, even if you're not going to go into this field of nursing. If you are going to work in any type of healthcare environment, which of course you are, you want to utilize these within your own practice. And the first is to believe the victim. I think we can all be very cynical in our minds, and we can also, it's very easy to victim blame. And that means, well, no wonder she was raped. She was walking downtown at 2 o'clock in the morning by herself, drunk, right? So then you say, well, no wonder she got raped. Well, that's not really the truth, right? The rape actually happens by the assailant. The assailant is the one who has taken advantage of this person in a vulnerable state. A human being who is acting in a compassionate manner would make sure that that person is safe. If they don't know them, to either get them to some facility who would be able to help them, such as the police department or a hospital, or if they do know them, get them home safely, get them tucked into bed, make sure they aren't going to choke on their own vomit if they vomit because they're drunk, and really just take care of them, right? Not rape them. And so always believe the victim in what the the unveiling of the details are. And it is not the time right now to say, you know what, you really shouldn't have been XYZ. That's not really the time to do it. Be not non-judgmental, which is what I talked about, and avoid victim blaming. Make sure that the victim has, or the survivor actually, has complete control over the examination. And what that means is I have things that I can offer them. I can do a head-to-toe examination. I can collect evidence. I can take photographs. But as we get to each section of that, the patient gets to decide. They can say, you know what, I don't want a head-to-toe examination. I really only want an examination of my genital anal area because that's where I was assaulted. Yep, that's okay. They can say, you know what, I really don't want a speculum exam to look if I have any damage on my cervix. I really just like you to collect evidence. Yep, we can do that. They may say, I don't want a physical examination at all. I just want antibiotics so that I make sure they don't come down with STDs, sexually transmitted diseases or infections that the assailant may have. Yep, we can do that. So the patient is always in control, and your job as a forensic nurse, or my job as a forensic nurse, is making sure they have enough information to make a good choice for them. We always offer impartial advocate. This is something that's required by the state, and that would be someone who can come in and be there completely for the patient. A forensic nurse has to remain objective, and objectivity means that I'm gathering evidence and I need to speak to that in a court of law. So while in most situations we are the advocate for our patients, and to some degree we are in forensic nursing as well, we also want to make sure they have somebody that's very confidential for them, that can't be forced to disclose information in a court of law, and an advocate cannot be forced to disclose information in a court of law like the nurses can. And we're very upfront about explaining that. Offer options, let the patient change their mind. Take care of physical injuries first. The first things we always ask them, are you in pain and are you bleeding? Let's take care of physical injuries first. Obtaining physical evidence is an option. That means, you know, are you going to give, should I collect your clothes, right? Underwear is a real good spot to gather DNA evidence from. And so, let's look at that option. Do you want to do that? And most forensic programs or sexual assault nurse programs will have underwear available for the survivor, the patient, to take home. They might have other clothing. I know my program had anywhere from t-shirts to sweatshirts to sweatpants to shorts to underwear to bras to briefs and boxers for men to underwear for children to clothing for children to socks to shoes, just all sorts. So if we have to collect them, or if they are things that they don't want to take home because of the memories that they would bring, then we can give them something. We support them emotionally, and we never allow the victim and the suspect to be in the facility at the same time. That would just be emotionally charged. So even though I might do the exam on the victim and the exam on the suspect, I would do them at different times. I would change my scrubs. I would wash my hands. I would document all of that. It would be done in different rooms. And then we connect them to the community resources that are going to help them. So is it rape crisis advocacy so that they can have counseling afterwards? Is it the DA's office so they can talk to somebody about their case? Is it law enforcement? Those types of things. Trauma-informed care. I did have you look at something this week regarding the messiest desk. And in the messiest desk, Dr. Rebecca Campbell talks about really what kind of emotions are triggered by people and what hormones are actually triggered. And so what we're talking about here with trauma-informed care is a little bit of an extension of that. Trauma-informed care would mean that we have to recognize that many people within the history have had traumatic events that can be triggered. And how do we go about as practitioners, and how does the facility go about as their policies and procedures to make sure that we're minimizing our ability to trigger something? Something as simple as when I meet somebody who I'm meeting for the first time and I'm going to do an exam on them, I say, I'm Kathy, I'm the forensic nurse examiner. I'm very happy to meet you. I'm really sorry it's under these circumstances. That is trauma-informed care. I'm recognizing that they have gone through something traumatic. I am truly happy I'm meeting them because I'm glad that they're safe. It takes courage to come in for an exam, and I'm glad I'm going to be able to do something for them. But I don't want to just stop it at that. I want to recognize for them that I realize they've been through a traumatic experience. The other would be, another example would be if I was going into a room with the patient and maybe a loved one and an advocate, and I'm going to go in there and I'm going to ask them questions. I may indeed allow them to go in first. I will not follow too far behind, because what if they were assaulted from behind? That would be very triggering to have somebody behind them not knowing what's going on. So I allow them to go in and I say, you sit where you feel comfortable. And we have a couch, we have a chair, we have a desk with a table. They can decide where they want to sit, and then I find a place to sit. I don't plop myself down on the couch and expect them to sit really nice and snugly with me next to me, because that might not be trauma-informed care for that individual. There has been a lot of talk over the last decade about untested sexual kits. So the Sexual Kit Initiative, or SAKI, Sexual Assault Kit Initiative, is really a nationwide event to bring the evidence up to date, to test all of those kits. Some places, I think Detroit was like 8,000 behind. I know Dane County was 3,000 behind, because if things weren't being pursued by the law enforcement or the DA's office, because maybe they thought that they wouldn't win the case, then the kits were not being tested. And here's the problem. If the kits aren't tested, then we don't know if we're dealing with serial rapists. If the kits aren't tested, we don't know if we have one person who's doing multiple assaults, because we can't link that DNA. And so there was an initiative several years ago in order to bring those all up to date. And a lot of states are up to date now and have enacted laws in order to keep those sexual assault kits up to date, with the approval, of course, of the patient or the survivor. And then we always ask the patient about their current relationship or recent relationships. And I want to stress to you as a practitioner that when you're asking this question, which you will ask a lot of times on admissions or in a clinic situation, where you're going to say, do you feel safe in your current relationships? Well, if you say, do you feel safe in your current relationships, and you turn your back and you're working on your paperwork, nobody's going to trust you to give them an answer. They're not going to give you an answer. What you want to say is, you want to turn around, you want to make eye contact, you want to use your best body language, and you're going to say, are you safe in your current relationship? And they say, yeah, I'm safe, I'm safe. And I say, let me ask it another way. Have you been hit or struck or slapped by someone within the past year? I can't tell you how many times I've asked that question and somebody has said, oh yeah, my boyfriend, my on and off boyfriend, yeah, last time we broke up was because he slapped me around pretty bad. And then you can talk to them about their safety plan and what they have, and do they have resources available to them. The other thing is that you want to ask them about, do they have control over their own money and finances? This will help, is one of the questions that helps us uncover human trafficking or sex trafficking. So there are others, there are good assessments out there and what the questions are that you should ask. One of them is just like with homelessness, where you say, where did you sleep last night? Do you have a permanent place to sleep? Those types of things. So you just want to make sure that you ask those questions very sincerely, because you do want to know the answers to help them. This is one thing I hope that I instill in you, that you never, ever ask. When I work in the emergency room and I've got a patient who has come in for a domestic violence situation, and I go and assess them, and then I come out to the nursing station, I've got to do some of my paperwork, pull up the computer, those kind of things. And I will inevitably hear an emergency department nurse or PA or nurse practitioner or physician or unit secretary say, why doesn't she just leave? It's much more complicated than that. The statistics tell us that a woman who is leaving a violent domestic violence situation, a woman who is leaving, is 7 times more likely to be murdered when she actually goes to permanently leave. And that's because it's about power and control. Remember, I told you it's about power and control. It is not about love. It is about someone losing control over somebody that they had groomed to have kind of under their thumb. And so it's very complicated. It could be complicated on that the person who is perpetrating this may be holding the children as collateral. If you leave, I'll hurt the children. And we've seen it in the news. We've seen people who are in domestic situations where they are going through a divorce, or they have tried to reconcile, and one of the parents has murdered the children, as the ultimate ultimate punishment for the other person. And it's just so sad when that happens. So they could do that. They could put pets. Some people are very attached to their pets, right? Pets are parts of our lives. They could say, you know, if you walk out the store, you're not going to be able to take, you know, the dog with you. And as soon as you walk out the door, the dog's dead. So there are also situations where they may have been put in a situation where they can't support themselves. So just saying, why don't they just leave? It is certainly not as simple as that. And I gave you a TED talk in your Blackboard assignments, and I think you just make sure you really watch it, because it really exemplifies what people go through. Here's a duck, because we're talking about some pretty heavy stuff, right? Cute little duck. Okay, we'll go on. Here's the cycle of abuse. So when somebody is in a violent situation, this is what will happen. And it can happen slowly, but it usually will escalate in intensity and frequency as the relationship goes on. So the tensions build. Usually the victim will say, I feel like I'm walking on eggshells when this phase happens. Then there's an incident, and that usually disperses that tension. And whether that is different acts, it doesn't matter whether it's emotional, but some incident happens. The abuser then professes that they're so sorry that if they did this, it will never happen again, and reconciles with the victim. And the victim's so happy that the abuse has stopped, and suddenly this person is acting nice again, that they kind of get sucked back into the cycle. And then there's this period of calm where everything is okay, and they'll refer to it as the honeymoon period. Oh yeah, he was bringing flowers home every night or whatever. And then the tensions build again. I do want to say throughout this PowerPoint, I talk about females a lot because about 98% of the victims of violence are females in sexual assault and domestic violence, but it happens to men too. It happens to transgender, gender fluid individuals, lesbian, homosexuals. It happens around, just around the gamut of the population that we see, but it's typically we will see women. So what will happen is maybe this first time this happened, it was a slap, and it took the victim back. And she said, I can't believe you slapped me. And he'll say, oh, I'm so sorry, I didn't mean to do that. You know, you pushed my buttons. And then there'll be that, they'll go around the cycle. Maybe the next time it happens, maybe it's not just a slap, maybe it's a punch. Goes around the cycle. Maybe the next time it's actually a push against the wall, and the victim hits her head and she bleeds. And now she says that she's really leaving. And then eventually they reconcile and go through it again. It does escalate like that. Sometimes I've seen patients come in, it's the 6th, 7th, 8th time they've come to the emergency department. Each time it's been more horrific for what they have been living through. And they really need a lot of support in order to safely leave that situation. And that is the reason we have domestic violence shelters around the country. We have one here in Ozaukee County. You can't look up where that address is because I don't want anybody knowing where it is, but if you work there, you know where it is, and it is well hidden. It is not something that you would drive by and think it's a domestic violence shelter. The one that I worked in, we would, be on alert for sometimes when we would know that an abuser was coming. And one in particular that I remember was actually the father of the woman who was at our shelter, and he had been sexually assaulting her since she was a young child, and he abused her quite a bit physically as well. And we were just very fearful of him coming and taking her away because he was threatening it. He somehow got the address, and we actually did have to call the police to have him removed off the premises. You have a picture of this in Blackboard, which is much better than this one. This one's a little grainy, but the power and control wheel really looks at the different ways that someone can hold power over another person. So I talked about using children and pets, right? But we could have denying or blaming. This is saying, you're making it so much worse than it really is. Oh, I didn't hit you that hard. If you want to see where this actually comes into play, if you look at any of the tapes from Johnny Depp with Amber Heard, that domestic abuse was really wide open in the courts, and there was a lot of this going on. There can be economic abuse. I'm going to cut you off from the paycheck. You don't work, I work. those types of things. And we talked about emotional abuse. Also, the perpetrator will look at trying to isolate over time that individual from family and friends, so they have nobody to turn to, no place to go. They may have worn out their welcome. They may have come to stay with their sister 5 times before and she's finally sick of it, those types of things. So we talked about the world's messiest desk. Please watch that YouTube video if you have not. And here's a kitten. It's important whenever you're giving a presentation on something as intense as sexual assault that you do give the individuals watching it a break mentally. Again, because of triggering and just being able to let them do that. Let's talk a moment about mandatory reporting. Mandatory reporting means that by law, you are expected or required to report to authorities when you suspect child abuse, elder abuse, or abuse of those who are intellectually or physically delayed. There's different reporting mechanisms. Let's concentrate on child abuse. If you have a child who comes into your hospital, let's say you're working emergency department. You have a child that comes into your hospital and you see on them what you suspect are bruises that really can't be explained by what the story is that the parent gave. It's important then to call in whatever authorities you have within the practitioners in your hospital setting to assess that. So it could be cigarette burns, it could be bruising. One of the common ones they say is that if a child isn't cruising, they shouldn't be bruising. Excuse me, which means if they're not up walking and cruising around furniture, then they really don't have many ways that they can actually bruise themselves. And so if they're not cruising, they shouldn't be bruising. Other things could be telltale. I told you cigarette burns. Also, if you have bruising around the face at all, if you have any bruising on like the feet, those types of things, those places just don't get bruised on infants and children. So it gets harder when the child starts walking and getting around, because then you're really trying to assess what are normal things. I mean, my kids walked around with, bruised knees and shins their entire young life. Well, but that's what we expect with children, right? They're out riding their bikes, they're playing at the playground, they're going to get hurt knees and shins. It gets particularly difficult, though, when we have injuries that we have to assess. And that is all what pediatric forensic nursing is about, is trying to assess those injuries. And how do we do that? Reporting abuse is just a simple phone call, and you will be well versed on this at the place that you work. So if you see something, report it. You're never going to be found at fault for reporting something that did not pan out. You cannot, you're protected by law, you cannot be sued by that person that you accused when you made the mandatory report. You say, I think it was the father who did this because he was acting XYZ. You can't be sued for that. You're protected by law. And a puppy. Okay, I want to talk a little bit about correctional nursing, because this is another part of forensic nursing, as is, and I didn't include a portion on this because I find so few students are actually interested, but I do want to let you know that forensic nursing also does death investigations. So in some places in the country, nurses are elected into coroner positions where they do autopsies and they investigate deaths. That would also be forensic nursing. I find it fascinating, but I know a lot of people don't, because you're looking at how can I help a living person. So I didn't include anything in here on that, but just so you know. Community health and correctional nursing. So correctional nursing is an area of forensic nursing, because forensic nursing really has to do with between legal and medical, so correctional fits into that. Correctional nursing is actually something that a lot of people really enjoy. When they get into it, they're usually into it for the rest of their career. They're kept very safe while they're in the facilities. I'll tell you, you don't hear about, right? You don't hear about it in the news where somebody says, oh yeah, again next week, a correctional nurse was, kidnapped or held hostage or whatever. It just doesn't happen. The correctional nurses are not only well protected, but well respected by the inmates in the correctional facilities. A lot of times the inmates have not had good health care before they got incarcerated. And so things are treated like their chronic diseases like diabetes or COPD, those kind of things are treated now where they really didn't excuse me, those treated when they were outside. So usually they, like I said, they had limited access. So you do have some challenges you don't encounter in other situations or settings. So you're autonomous. Now you're going to find that in any of the forensic nursing roles, you're going to be autonomous, meaning you're really relying on what you've learned and the resources you have and who you can reach out to, because you don't have a team there that actually is going through this experience with you. So it's not the same as having a team within acute care, you know, your team up on the floor or whatever. But I will say, within most correctional facilities, you do have a team of nurses, or you might have physical therapists or occupational therapists. So you're not going through these experiences completely on your own. You're responsible for triaging inmates during entry or sick call, routine treatments and medications, operating within the constraints of the security system, right? So you wouldn't take any undue necessary risks. And there is sometimes a potential for conflict between what we feel as nurses is the right thing for this inmate and perhaps what the correctional facility feels is the right thing. So those things just need to be worked out and talked about. And you need to balance the healthcare needs with the security needs, like I talked about. So the different settings are prison, jail, juvenile detention facilities, and we have seen an increase in incarcerated populations over like the last 20 years, but I'll say COVID has really decreased them because a lot of people have been let out of prison, out of jail, out of juvenile correction facilities if they are deemed that they don't absolutely need to be there because of COVID, because we have a population that's together and they're within a very confined area. And so we have outbreaks within the prison systems. And so they've been doing that. But we have seen historically before COVID an increase in incarceration. And there's been a lot of talk about how to take care of that. That's for another subject, another topic. So they have the constitutional right to have health care, and we have the responsibility to do it at a minimal cost to society. And of course, there's a potential for when they come into this population in order to spread communicable diseases like TB, like HIV, like those kind of things. There's also PREA laws that are enacted federally throughout all states, and that is the prevention of rape to the incarcerated prisoner, PREA law. And so there are guidelines now for when someone says that they have been raped or sexually assaulted within a prison system. There's many ethical considerations, but they're no different really than what you would face in an acute care setting. So I mean, as a floor nurse, I mean, I've taken care of several people who were harmed in the committing of crimes. I took care of an individual who had his one hand blown off because he was putting a pipe bomb someplace in order to harm somebody. Taking care of a couple of people who were participating in murder-suicide, where they murdered another person and they were trying to take themselves, but they weren't successful. They only blew off half their face instead of their whole face or whatever. And so you always have that ownership of saying, I'm going to provide the absolute best care to this individual regardless of what they've done. And so a lot of prison nurses will say that. In fact, I know a couple of prison nurses who will say, I really don't even want to know why they're in. It's just best that I don't. And I'll say that about when I do suspect exams. When I swabbed for DNA evidence on suspect exams, my mental status is, I don't know whether they did it or not. Don't really care. I'm just going to do my job. And when we do suspect exams, we do have a couple of officers in the room with us. This is the National Commission of Correctional Health Care, and they do have some responsibilities listed here. I'm not going to take time to read all of them for you. So the role of the correctional nurse, there's many things. I'll just highlight a couple of them. So they really are going to promote adequate rest and physical activity by inmates. They can actually see that as they assess their inmate population as to whether or not someone is being unduly stressed, whether they the activities that they're expected to participate in are really harming them in an undue fashion, medically speaking, versus what is really necessary for rehabilitation. They're also advocates for adequate space and facilities for sleeping because they know that that can change someone's mental status, their ability to handle stress, and their ability to respond within a social situation. I know that I've done a couple of where we've had inmates come in for parenting skills and for understanding how to do prenatal care. So here are some of we talk about primary prevention, prevent illness or infectious disease. So TB, using universal precautions. Of course, quarantine is really big right now. And then looking at preventing injuries as far as suicide, violence or aggression towards others, and then anger management, which they may need to work on. So that's it for our PowerPoint. I know that we have this week you're completing your practice test for ATI or Kaplan. Remember, you only have one. You don't have to do both. And those drop boxes are found in Blackboard under those respective titles, ATI or Kaplan. And then I've done a little bit of adjustment to your schedule. I have decided that during week 13, we will take our ATI and or Kaplan tests in class rather than trying to schedule them outside of class. I heard from a lot of you that that was going to be very difficult to try to do, and so I certainly hear you, and we'll do that. We're going to have that week called kind of pulling it all together. You do a couple of case studies as your homework, and then you'll come in and during your class time take your ATI or Kaplan integrated tests, and then you'll do remediation on those based on a table that you will find under week 13. And so if you do really, 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 really poorly, then you've got about 3 hours of remediation that I'm asking you to do. If you do really, 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 really well, you aren't going to have any remediation. So take the time this week during your practice tests in order to start gathering the information you need in your head in order to do well on the integrated tests, okay? I know there's going to be some questions on the integrated tests that are going to seem challenging. It's just the way it is. It's supposed to prepare you for NCLEX, and NCLEX is challenging. So see me if you have any questions about that. But when you take your Kaplan test or ATI test during week 13, the one that counts, you'll get 3% of your grade for actually taking the test and 2% of your grade for completing the remediation as you're asked. And you don't get any credit for partial remediation. So if I ask you to do 2 hours, you need to do 2 hours in order to get that 2% of your grade. Okay, you're adults, you can figure that out, but you reach out to me if you have any questions on it. Okay, that's it for this week. I hope you have a great week. Stay safe and stay healthy, and I will see you next week.